Good day, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. It is my pleasure to welcome you today to our webinar on the value of healthcare e-payments. Before we begin, I'd like to mention some logistical items. You can download a copy of today's presentation from the CAQH.org website. To do so, navigate to the Core pull-down menu at the top of the CAQH.org welcome screen and select the Coeducation Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. We will save time at the end of today's program dedicated to responding to audience questions. You are encouraged to submit your questions at any time during this webinar by typing them into the questions panel on your dashboard. We do ask that when you submit your questions, you identify the type of organization you are with so we can give you a more accurate response. We would like to thank our guest speakers from NACHA and WEDI for joining us today. We will properly introduce them a little later, but want to extend our appreciation to Priscilla Holland, Senior Director of Healthcare Payments at NACHA, and Robert Tennant, Director of HIT Policy at MGMA, and he is here today representing WEDI. Today, we have a lot of ground to cover. We will start off with a high-level overview of the mandated Phase 3 operating rules and associated maintenance activities, followed by a presentation by one of our CAQH colleagues about the CAQH Index, including trends in adoption of the EFT and ERA transactions. After that, we will have NACHA describe the NACHA CCD Plus specifications and the value of having an electronic healthcare EFT standard, followed by WEDI giving an overview of the electronic payments guiding principles. Let me catch my breath. And then, in a Q&A format, we'll talk to our guest speakers about the benefits and some of the challenges surrounding the use of healthcare e-payments and leave you with some useful tips and best practices. And we'll save time at the end of all of that to answer some of your questions. And now, I'd like to introduce our first speaker, CAQH Core Associate Director, Erin Richter-Weber. Erin?
Thanks, Jessica, and good afternoon, everyone. I am going to give a very quick overview of some of the key regulations and requirements related to EFT and ERA out there right now. To start off on this first slide, I just want to recognize that there is a mandated healthcare EFT standard as of July 2012. There is also a mandated ERA standard that has been in place for many more years. Additionally, the CAQH Core EFT and ERA operating rules were mandated for implementation by all HIPAA-covered entities in 2013. The compliance date for both these items was January 1, 2014. So all HIPAA-covered entities at this point in time should be operating in compliance with the EFT standard and the EFT and ERA operating rules. Next slide. The Phase 3 operating rules address some key challenges identified by the industry during operating rule development. I'm going to walk through at a very high level some of the issues that are addressed by the operating rules. The first is CAQH Core Rule 360, the uniform use of CARCs and RARCs. Providers expressed challenges with health plans inconsistently using the adjustment and denial codes included in the 835. This rule sets forth some set code combinations so that there's more consistency across the health plans, allowing providers to automate their systems. There's an infrastructure rule that supports the 835 transaction and applies the core infrastructure requirements such as system availability, companion guide templates, etc., to the 835 transaction for ERA. There is a reassociation rule. One of the big challenges providers identified was reassociating the EFT transaction with the ERA transaction because the data and dollars flow separately. It needs to be reconciled at the end of the process to ensure that providers are being paid for the services that they provide. So there are requirements within this operating rule to ensure that providers are receiving this information within a similar time frame and that the information on both transactions allows them to match together. Finally, there are two rules addressing enrollment, provider enrollment in EFT and ERA. Providers noted a challenge was that there are very different enrollment processes for these transactions across health plans. And these rules set forth a common data set for enrolling in these transactions so that providers know what will be expected of them when they want to start using one of these transactions with a health plan. Next slide. There's a lot of benefits to the EFT and ERA operating rules. Hopefully many of the providers on the phone are already experiencing many of these. Obviously the standardized enrollment makes the enrollment process more streamlined. There's a reduction in claim rework if the denial and adjustment codes are being used consistently. And generally improvements in the revenue cycle. CMS estimated in their final rule for the EFT and ERA operating rules that the industry would save between $300 million and $3.3 billion over 10 years across the health system using the EFT standard and the operating rules. That's quite a bit of savings, and I know Raynard's going to get into more detail on that in a minute. Next slide. Within the Phase 3 EFT and ERA operating rules, there is some ongoing maintenance required. So while the rules were required for implementation back in 2014, the CAQH core participants are still conducting quite a bit of work to ensure these rules are meeting the industry's need. The first maintenance process is related to the core code combinations in that uniform use of CARCs and RARCs rule. The goal of this process is to address the need for those code combinations to align with the published CARC and RARC lists from the respective code maintenance committees and to address ongoing and evolving industry needs. Those code lists are updated every 4 months, and so the code combinations themselves also need to be updated. The other maintenance process is related to the EFT and ERA enrollment data sets. The core participants recognize that industry needs may change or evolve over time, and the data needed when a provider is enrolling in EFT and ERA may change over time. So this process allows the industry to incorporate lessons learned from increased enrollment to address these changing business needs. Next slide. A little more detail here on how the uniform use of CARCs and RARCs rule impacts denials management. So you have these 3 types of codes, CARCs, RARCs, and group codes. And as I mentioned, they are updated, with the exception of the group codes, the CARCs and RARCs are updated 3 times a year. And health plans before the rule were not regularly updating their data sets as the codes were updated, and also they were inconsistently using the codes. So the core code combinations maintenance process ensures a consistent and uniform use of a subset of business scenarios related to these codes. Next slide. This slide illustrates the 4 business scenarios addressed by the core code combinations, and these are kind of the 80-20 of the challenge providers recognize where these codes are being used inconsistently. So missing invalid incomplete documentation, missing data from a claim, billed service not covered, and billed service not separately payable. And there are code combinations within each of these business scenarios to address specific situations. There are 2 types of review processes included in the code combinations maintenance process. One occurs 3 times a year, and that's a compliance-based review, and it is triggered by updates made to those published CARC and RARC lists to ensure alignment. There's also an annual market-based review to consider industry submissions for any adjustments to the code combinations based on business needs. And that market-based process is actually launching within the next couple of weeks. So for providers out there who may have challenges with current code combinations, this is your opportunity to impact how health plans are using them moving forward. Next slide. The enrollment data rules have great impact in ensuring providers have a consistent enrollment situation. They enable health plans to collect standardized data from complex organizational structures and relationships. And it simplifies EFT and enrollment by having health plans collect the same consistent data from all providers. Next slide. The maintenance process associated with this is also currently active, and There are two types of review that occur as part of this. One is a limited review, and that's what's currently in process right now. And that is when the task group considers any non-substantive adjustments to the data sets. HIPAA-covered entities will not need to update their enrollment forms. There are also comprehensive reviews, and the next comprehensive review is scheduled for next year. And that is the opportunity for the industry to consider substantive and non-substantive review to the data sets. For example, are there new data elements that are needed, or are there data elements that are not being used that can be removed from the data set to simplify the process? So keep your eyes and ears open for opportunities to get involved in that maintenance process. Next slide. And finally, I just want to highlight another tool from CAQH solution side, and that is CAQH Enroll Hub. This is a web-based data entry tool for provider enrollment in EFT and ERA. This tool is compliant with federally mandated operating rules and allows providers to go to one single place for free and enroll with multiple health plans. So you only have to enter your data once for those health plans that are using Enroll Hub. It really reduces the administrative burden on the providers. And with that, I believe I'm going to turn it over to Reynard to talk a little bit more about the CAQH index data related to EFT and ERA. Reynard?
Great. Thanks, Erin. So I'm Reynard Washington. I work here at CAQH on the index and some of our other research initiatives. So I'll talk just for a few minutes about the index and the work that we're doing to track the adoption of both EFT as well as ERA within the commercial industry. The CAQH index, for those who may or may not know, has been around for about 4 years, and we've been working over that time to understand and monitor the use of the HIPAA electronic transactions, or HIPAA standards for electronic transactions over the course of that time. It is a voluntary survey of health plans, so we basically get data from health plans, both medical and dental and healthcare providers on an annual basis, basically an aggregate to understand how many individuals are conducting transactions electronically, and in the case of EFT and ERA, of course, how many payments and remittances are being sent electronically. We do have an advisory council that we work with very closely that helps to guide the work that we do and helps to standardize and give us and consult with us on best approaches to continue to enhance and grow the index over time. So the index, as I mentioned, is currently tracking 12 of the electronic transactions that occur mostly in the claims cycle, but some of them are outside the claims cycle, specifically those that are related to enrollment and premium payments. We've added, over the last 3 years, we've been sort of sequentially adding transactions to our data collection tool so that we can establish industry benchmarks across all 12 of those transactions. And so as of 2015, we are currently tracking all of the HIPAA mandated transactions, and you can see which ones here actually currently have standards that have been adopted by HIPAA, as well as operating rules that are federally mandated. So I'm just going to limit my discussion today for just a couple of minutes to talk about some of the data we have on electronic funds transfer and ERA. And so, like I said, we've been tracking for the last 3 years, and for those who are curious, within the next couple of months, we'll be releasing data for the 2016 index report, which will have data on adoption rates for 2015. But as you can see from this slide, adoption of electronic transactions has been increasing pretty steadily over the last 3 years for EFT and ERA. We believe adoption for EFT is at about 60%, and ERA is a little bit less, about 51%. It's important to note, though, that there is some variation across health plans, and so we do have a very wide range of plans that participate and provide data. So in addition to producing industry benchmarks, we do produce company-based benchmarks for them so they're able to understand how they compare to the rest of the industry. And so I'll just note that, adoption does vary pretty dramatically across the health plans that are currently participating, and this is specifically just the commercial health plans. And so we see a huge range in both payment adoption as well as remittance adoption. The second thing that we do in the index is we try to estimate the cost savings associated with adopting EFT and ERA, as well as other transactions. And we do this by using a variety of methods to basically try to estimate the fully loaded direct cost related mostly to staffing, but also to some of the vendor and overhead costs that might be related to conducting the transaction. So this next slide shows you where we estimate the cost savings or the potential cost of conducting EFT compared to the traditional methods of a paper check, as well as remittance that's sent electronically versus the remittance that's sent manually. And so you see here, we see on average about a $2 cost savings for the industry for remittances and a $1 cost savings per transaction. And so Priscilla in a second will talk a little bit about how many transactions are flowing across the industry, but this is tons of transactions when you think about it. And so if we're able to convert all of these manual transactions to electronic transactions, we get to those millions of dollars that Aaron highlighted just a little while ago. So the next slide, we actually show what we do on an annual basis to try to estimate how much we think the industry could save if all of the providers and plans would in fact adopt electronic transactions to conduct payment and remittance or to transmit payment and remittance. And you see from this slide, we estimate that over $6 million could be saved annually just from these two transactions alone. So if we were to get all providers to enroll in the EFT payment and set up systems to be able to receive their remittances electronically, we believe the industry could be saving $600 million a year, which is quite a substantial cost savings. And the majority of that cost savings actually is being would be on the provider side as opposed to the health plan side. So that's what we estimate. About $400 million of that is related to costs that are incurred on the provider side. And much of this is, again, related to labor that's associated with either processing or posting manual checks or having to process or reconcile remittances with checks. And, of course, the additional follow-up time, which we're working towards now to be able to better characterize or estimate how much time is actually spent in that follow-up period. So with that, if you have more interest in the index or some of these findings, feel free to take a look at the report. Thank you.
Thank you so much, Reynard. And now I'd like to introduce Priscilla Holland, Senior Director of Healthcare Payments at NACHA. In that role, she leads NACHA's Healthcare Payments Program and works on other payments and remittance information and standards projects. Priscilla, welcome.
Thank you very much. Let's go to the first slide, the next slide, please. As Aaron indicated earlier, the healthcare EFT standard was identified in 2012, and it was identified as the NACHA CCD +1 addenda record, and that became effective January 1st of 2014. So what does that mean? What it is NACHA, who does the rules and guidelines for the ACH network. We have a variety of formats. The one that was identified as the healthcare EFT standard is an ACH business-to-business payment, and it has one record that is attached to the payment that allows you to carry 80 characters of information. And in that addenda record, you must carry, based on the regulation that was passed, the TRN reassociation trace number. Now that's as defined in the X12-835 version 5010 implementation guide. So the standard is the business-to-business transaction, the CCD. You have to have the addenda record that carries the TRN reassociation trace number, and that trace number is actually used to auto-reconcile the ACH payment to the electronic remittance advice. So the TRN is carried in the ERA, and it is carried in the ACH payment. Now, for the providers to receive that TRN reassociation trace number from their financial institution, because the payment does go to your bank account, the providers need to go to their bank and ask their bank to set up the process to deliver that information to the provider so they can reconcile the payment to the appropriate electronic remittance advice. Now, the key piece of this is that all health plans must be able to deliver the healthcare EFT standard for your claim payment if it is requested by the provider. It is not optional. If the providers go to the health plan and say, I want to receive this, the health plans have to be able to deliver it. Now, if you go to the next slide, please. In 2013, NACHA passed a change to our operating rules that allows us to be able to track and identify the healthcare EFT standards that are processed through the ACH network. So it's actually giving the healthcare industry the first actual count of the ACH transactions that are being processed to make healthcare claim payments. And we've seen a significant growth in those payments since this our change was implemented in 2013, and then the standard became effective January of 2014. And if you notice, there's a continued increase. There's some ups and downs, but it continues to move, and the volume continues to increase. And if we go to the next slide, we can look at some of the trends that we're seeing in the industry. In 2014, we actually saw a 104% increase. That's the first year the standard was effective. From January, the monthly volume from January to comparing to the monthly volume in December of 2014, there was a 104% increase. Now, if you look at 2015 volumes, compared to 2014 volumes, there was actually a 39% increase in that volume, and we continue to see the volumes increase in 2016. Looking at the January to October, we've seen about a 26% increase in those transactions through 2016. Now, I've had a number of people question going, well, how much of that is actually Medicare volume? And we went to Medicare and compared the July volumes, and actually Medicare is only about 3% of the transaction volume on a monthly basis. So in July we saw 19.3 million transactions, or healthcare EFT transactions, go through the ACH network, and only 3% of that was for Medicare. So it is something we continue to see grow in the private sector. There is still room for more growth. As Renard said earlier, we're looking at about 61% of the healthcare payments or claim payments are being made via ACH, and we'd like to see that increase because of the amount of money that the industry can save in automating their back office process. Now, what we see is most of the large hospitals, the provider groups, and the pharmacies have moved to receiving the healthcare EFT standard for their claims reimbursement. The challenge that we're finding is reaching the smaller organizations, the individual provider practices, the smaller group practices, and the smaller hospitals. So we're really looking at how to reach out to those groups to be able to help them move to the healthcare EFT standard. So if you go to the next slide, please. One of the things NACHA has done this year is worked with the group called ITE, and they are a research firm. We co-sponsored a study with them looking at the barriers to the healthcare EFT standard implementation for providers in less than $50 million in revenue on an annual basis. And the barriers that we came across were being charged, or the number one barrier is being charged a percentage-based fee based off the total reimbursement amount for delivery of the healthcare EFT standard. Rob's going to talk about some guiding principles that we're putting in place that actually state that the health plans should be offering a free delivery of a healthcare EFT standard. This is something we're hoping to implement to help offset this primary barrier. One of the other ones is the cost to modify internal systems to reconcile and reassociate, because the auto reconciliation and reassociation is really where the big savings are to the provider with moving to the EFT standard and the ERA. And then the third barrier that we've identified is the time it takes to enroll with each health plan. And Aaron mentioned the CAQH Enroll Hub, which is something that is available to providers free of charge to help them enroll with multiple health plans by only implementing or entering their information in once. And so it does help make that barrier go away for a lot of the health plans. And then the patient accounting systems, the auto-posting capability, and then there is the last barrier that was identified was supplying bank account information to health plans. So there are a number of things out there that are barriers. We're looking at ways to resolve those barriers. I know supplying bank account information to health plans. There are procedures and policies in place that people need to take care of or secure that information, but there are things out there that can help a provider work through a number of these barriers, and there are resources available. And one of the things I neglected to put on my slide was NACHA's. We have a website. It's healthcare.nacha.org, which is our healthcare payments resource site, and it does provide a significant amount of information for helping implement the healthcare EFT standard. And at this point, I'm going to turn this over to Rob, and he's going to talk about the guiding principles that were developed.
Well, before, thank you, Priscilla, and before Rob's presentation, let me take a brief moment to properly introduce him. As I said before, he's the Director of HIT Policy at the Medical Group Management Association. In that capacity, he focuses on federal legislative and regulatory information technology issues included in HIPAA, administrative simplification, federal quality reporting programs, EHR policy, MACRA, and other HIT topics, and he's here today representing WEDI. So Rob, please feel free to begin when you're ready.
Thanks, Jessica, and welcome to everybody. First of all, I wanted to thank CAQH for inviting me to participate on this program. For those that aren't familiar with WEDI, the Work Group for Electronic Data Interchange was actually named in HIPAA as an advisor body to the Department of Health and Human Services. It's a multi-stakeholder, nonprofit organization that has providers, health plans, vendors, clearinghouses, and the government actually gets involved. So it's a great organization to try to get things changed. As you heard from Aaron and Priscilla, we have plenty of wonderful regulations guiding the e-payments world. So the question is, why haven't we moved ahead as aggressively as we could have with electronic funds transfer? And so we looked at this at WEDI, and frankly, we made the decision that we needed to provide more guidance to the industry, because obviously, adoption rates were not as high as we wanted. But as Priscilla suggested, we were seeing about a quarter of all EFT payments come to providers with a fee attached, and many of us in the provider world, frankly, felt that was simply unfair. We also saw the really the explosion in the use of these virtual credit cards, these single-use 16-digit numbers that require providers to use their own credit card machines to process the payment, and of course the provider is responsible for paying all of those merchant fees. We at MGMA found that when we surveyed our members, 87% received these virtual card payments without any prior consent or notification from the health plan or vendor who was issuing them. As well, some 70% said that their health plans provided absolutely no instruction on how they could move away from virtual cards and start adopting EFT. Making things even more challenging, frankly, the government has really not stepped up to provide the type of oversight and enforcement that they should have. And so we at WEDI decided to move ahead on our own as an industry to try to really develop what we would call best practices for the industry. Next slide, please. So we formed this task force with the goal of driving up adoption of EFT and frankly increasing the transparency for virtual cards so providers would know exactly what to expect and what was happening. We made sure that the task force was comprised of all of the key stakeholders. We had multiple conference calls. We had many drafts. There was a lot of back and forth with the task force members over a period of several months. And finally, in September, we released the principles to the world, and they're available, of course, for download at wedi.org. So next slide. So here, you will see that what we did with the document was basically provide an overview for those that weren't as familiar with the e-payments issue, a little bit of background of why we tried to move ahead. We laid out the Affordable Care Act requirements, standards, operating rules, and then we went into the guiding principles. So next slide. I'm just going to walk through a few of these principles, and I think you'll see that there's a definite theme when we're looking at these. So for example, once you decide you want to begin accepting EFT payments, the enrollment process should take no more than 30 days. There also should be no delay of ongoing payments when a provider decides to begin receiving any form of electronic payment. Next slide. Very importantly, again, to get to the transparency issue, providers should be notified regarding any fees associated with any of the e-payment methods. Providers should be informed to check with their contracted vendors, for example, their MasterCard or Visa merchant processors, regarding any additional administrative fees, and providers should be notified about the availability of the ACH EFT payment option. So even if a paper check or a virtual card is sent, providers should be notified that there is a better way. Next slide, please. Before a provider can be paid through, for example, a virtual card, it should be opt-in. They should be given the option of deciding whether or not they want to accept that particular form of payment. And as well, very importantly, as Priscilla suggested, if a health plan, vendor, clearinghouse, if they're offering EFT, they should offer it with no fee attached to it, at least an option. There may be other services vendors and payers can provide, but at a minimum, there should be a no-cost option. Next slide, please. Great, and there also should be transparency from the sender side. Providers should be given a minimum 90-day notice if a health plan is moving away from paper checks, and again, give the provider enough notice to make a conscious and wise and educated decision on how they want to be paid. And there's also, sort of the concern in the provider community that if they move to the ACH EFT approach, that the payer who believes they may have sent a provider an overpayment will simply go into the bank account and scoop out that money. So here we're saying there must be explicit authorization prior to any debit transaction for recoupment purposes. Next slide, please. And I just wanted to take a minute to recognize the folks that were involved with the task force, my co-chair, Jay Eisenstock from Aetna, but also Aaron and Priscilla, who are faculty on this program. They were instrumental in getting the document finished. And as you can see from the names here, representing CAQH, health plans, the AMA, MasterCard, EdFX, a whole wide variety, including CMS. So we're very proud of this, and I would encourage you to go to wedi.org and review the principles. Thanks so much, and I will turn it over to Drew.
Wonderful. Thank you so much, Rob and Priscilla. And so we just wanted to get the audience involved a little bit today. This is our first of 2 webinar polls that we'll have, just to take a quick pulse of the audience. And I will read the question, and then you will see a poll appear on your screen for you to log your response. So this question asks, please indicate the extent to which your organization sends or receives healthcare payments through EFT. And this is through the ACH network. So we'll launch this poll, and you should see it come up on your screen. So please select your option, and then I'll share the results maybe after about 15 seconds.
You know, and the reason why this question helps us and why we're asking it is because we're trying to get an idea of who's on. You know, are you guys, you know, well-versed in this? Are you new and need more information? If you don't know, feel free to fill out that number 5, that NA, but it really does help us out.
And it helps our audience kind of get a feel about what other people are doing. So we'll take about 2 more seconds. Please log your result, and I will share the results here. All right, I'll close the poll and share the results. You should see them come up here. So 12% are saying 1 to 25%, 21% saying 26 to 50, 51 to 75%. We have about 24%, the majority there, and then back to 21% above 75, and then 22% saying not applicable. So interesting to see. In the interest of time, I think we'll move on. And Jessica, I'll turn it back to you.
Thank you so much, Drew. I'll be moderating this next portion of the webinar, and I'm excited to, you know, get a chance to ask a couple of questions to our speakers, Priscilla, Rob, Reynard, and Aaron. So let's begin. So my first question was really going to be directed at Aaron, but I think given what I've heard in this presentation, I think this is a question for anybody who's interested in commenting. So for the providers that are on the line right now, who are looking to make their payments efficient, because I mean everybody is, what would you say to them? You know, what can they gain from using these transactions? Can I start out with Aaron, but I think also we'll open it up for Rob, Priscilla, Reynard to comment.
Yeah, absolutely. Thanks, Jessica. I think you saw the data that Reynard shared about the impact these transactions can have on your practice. So I would say that that is the first thing to think about. In terms of some of the barriers that Priscilla spoke about, you know, the difference between a paper check and an EFT, there's a lot of time involved in processing a paper check. The security is not as great. So there's a lot of reasons to consider transitioning to EFT and ERA. And if you're interested in getting started, I would say some of the first places you should go is to the plan's website to see how you can enroll, to CAQH Enroll Hub to see what plans are offering enrollment through Enroll Hub. So there's a lot of ways to start the process. Others, feel free to join in.
Yeah, it's Rob here, and let me just add, one of the real value points here is not just with the payment, but it's the reassociation with the remittance advice. Because when you've got a manual process in the back end of a practice, it is labor intensive to identify problem payments, payments you need to rework, remittances that don't seem to match with the payments. With the trace number, which was mentioned earlier, is absolutely critical for that reassociation and can dramatically lower your staff time involved with the payment end of the revenue cycle.
And this is Priscilla. I want to add to that because Rob is spot on with that. But we have, NACHA has some case studies that are posted on our website. And we have a mid-sized practice out of the Chicago area. And one of the value propositions that they found, and they are at about 95% of their payments and their remittance advices are electronic. So they are able to receive the payments electronically and post them electronically. And what they've found is they've been able to improve their cash flow significantly because when they started moving to electronics, they were at about 25 days in their receivables process. They have been able to move that down to 13 days. So that, one, improves their cash flow, but it also allows them to post the transactions electronically, and it speeds up their billing process to the actual patient. So they can file their secondary billing faster, and they can also bill their patients faster. The other thing that they have found is that they've actually, over 7 years, they've been able to double the size of the practice and the claims that they've filed, and they have not had to add to staff in their receivables and payables department doing that because it is a fully automated process for them, and it allows their staff to handle more transactions faster with less posting errors, and then it again allows them to speed up the billing to their patients. And as you all know, getting that correct bill to the patients faster means that you are more likely to get those funds from your patients. So it's a win-win all the way across.
Thank you. That's really helpful information. Rob, as a provider representative, what type of education are providers receiving on this, and do you think, do you see any gaps or any areas where we should be providing more information?
Yeah, good question. Obviously, we have a lot of educational resources through MGMA. We have an EFT ERA toolkit which sort of walks our members through what they need to do. There's a sample letter to receive EFT payments. But let me just put a note of caution out there, because in what we've been hearing from our members is they are receiving communications from health plans and from vendors trying to sell them on these virtual cards, making it seem like they're electronic payments very similar to EFT, that there's administrative savings, and they're very non-transparent in terms of the fees attached to them. So I would just encourage the listeners to be wary and to definitely read the fine print.
That's great, and that's very helpful. Aaron, I had a question for you. Since you worked on the guiding principles, and obviously you represent CORE and we're very involved in the operating rules, do you see connections or overlap between the operating rules and the guiding principles?
Absolutely, and if you take a closer look at the guiding principles document, as that document was being developed, and Rob, you can probably describe this better than I, the number of guiding principles expanded and decreased as the group debated and discussed what the key components really were. And some of the things that were in there initially were actually components of the operating rules. And so some of those key things were taken out and put in a section of that document that outlines what the federal mandates are. But it's interesting that not only are they operating rule requirements, but they came out as something that should really be principles that the industry should be adhering by. So there was sort of the mandate, but also the value of the rule requirement that was also being recognized as part of that process. So I think the principles really do complement the operating rules, and they take the operating rules a step further where the industry might not have been quite ready for a mandate. It provides a guide path for the industry as to where we should be heading in terms of electronic payments.
Yeah, it's Rob again, and if I can just add to that, one of the things that came out of the guiding principles, and keep in mind these are voluntary, these are not sort of mandated on the industry, but CMS was involved, and I've had conversations subsequent to the release of the guiding principles, and CMS apparently is very interested in turning some of the principles into sub-regulatory guidance. So we will be watching for this over the next few months, because frankly the one sub-regulatory guidance document that CMS did put out, in fact it said that health plans were not permitted to charge, quote, excessive fees for EFT, unfortunately CMS removed that FAQ from their website. So we're hopeful, as we say in Washington, cautiously optimistic that CMS will leverage the principles and release a broad set of sub-regulatory guidance to mandate these on the industry.
Thank you, Rob. That's helpful and it's really critical. You know, it's a kind of a piece of information that clarification that seems to be needed. So Reynard, just to change the subject a bit, and you know, some of the questions that have popped up during the webinar have been, where can I find the index? When's the next index coming out? So clearly people are hungry for this information. So what's next for the index and when can we expect the next one to be released?
Yeah, sure. So you can always find information about the index at CAQHindex.org, and it'll take you straight to the homepage. Again, that's CAQHindex.org. The 2016 index, which will have data representing adoption and cost for 2015, will be released towards the end of December, but we won't, I'm sorry, actually it'll be released in early January. We'll have another big webinar on January the 12th. So look forward to more information about the webinar and how to register. Of course, it's always free, so it'll be on January the 12th for sure. But I'll tell you, just to look forward to this index, we did a lot of work this year to expand some of the healthcare provider cost estimates to better account for some of the additional workflow that goes into having to conduct the transactions and also trying to estimate some of the time associated with processing the transactions and really the differential time as a measure of efficiency. So this year we'll have a couple of new estimates that folks will be able to use as they try to understand how, in fact, automation can potentially benefit your practice and your organization.
Thank you, Reynard. And for those of you who are interested in the webinar that Reynard mentioned, go to CAQH.org and you should be able to register there. Now, my last question is for Priscilla, and once again, if any of the speakers want to pipe in, but I'd like to kind of end this part of the webinar on a forward-looking looking forward. So Priscilla, from what you see in your line of work with new and advanced technologies and also the data that you see month by month, what do you think we'll be seeing? Is it a transition to more e-payments, or have we reached kind of a point of maximum gain? What do you think is going to happen?
I really think we're going to continue to see an increase in the number of payments that are paid electronically. As the health plans are looking to improve their back office process, they want to move away from checks. And I know some of the big health plans are working with their providers to move them off of checks completely and move them to ACA, the healthcare EFT standard, or virtual cards. They're being given a choice. So you see a lot of the health plans trying to move to a standardized process and to move to electronics. So on that side, you see a movement of more payments to either the healthcare EFT standard or the virtual card. From a provider perspective, the large organizations or larger health hospitals, health plan, or provider groups, sorry, have already moved to electronics. So we're seeing this move down the size of the organization and move into the smaller practices. But I do expect that we're going to continue to see a movement away from paper checks and to electronics, and hopefully for the providers that they move to the healthcare EFT standard, which will save them money. And if, as Rob says, CMS does put some guidance out around the guiding principles, that will help make sure that the providers are not charged to deliver the healthcare EFT standard by the health plans or their vendors. So I do see it continuing to grow.
It's Rob here. Let me just add to that, because I think Priscilla is 100% right. What we hope as well is if we can get this transaction right, the EFT, if because a lot of us feel that it's the lowest hanging fruit on the EDI tree, that it's a relatively simple process. As long as there's not fees attached, I think it'll grow in use, but we hope it will be a stepping stone. Once practices see the value of automating the back end of the revenue cycle, the payment and the remittance, we're hopeful that they'll start looking at the other components of the revenue cycle. So for example, move to automated electronic eligibility. We think that's a huge opportunity as well to save money in the practice. And just a little shout out to CORE. CAQH CORE has developed a very, very robust set of operating rules to make checking patient insurance eligibility much, much easier. So again, we hope that this is the transaction that drives the rest of the industry to move to more automated solutions.
Well, thank you so much to our guest speakers and Reynard and Aaron for this part of the conversation. I'm going to turn it over to Drew for our next poll.
Great. Thank you, everyone. And this is our last polling question of the webinar. Just like last time, I'll ask the question, and then we'll open the poll for everyone to respond. And this question asks, please indicate the extent to which your organization sends or receives remittance advice data using the ASCX 12 version 5010-835. And I will open this poll. You should see it come through now. So just take a couple seconds, and we'll share the results when it's done, and then we'll move into our audience Q&A portion of the webinar. Take about 5 seconds. Take about a couple more seconds, and then I'll share the results here. All right, I'm going to close the poll and display the results. So number one, 6% indicate 1 to 25% of the time. 14% of those that responded indicate 26 to 50%, 18% indicating 51 to 75%, and then above 75%, it was 30%. The largest, 32% indicating not applicable. Well, for, again, the interest of time, we'll move on into audience Q&A. So send in your Q&A, your questions, and then I'll turn it over to Jessica.
Thanks so much. We do have a couple of questions that I'd like to get through. And the first question is a question for Aaron. So what can be done to make the payers use the standard reason remark codes correctly on the ERA?
That's a good question. You know, I spoke earlier about the Core 360 rule, which addresses uniform use of the CARCs and RARCs through the core code combinations. If you feel like your health plans are not in compliance with the core code combinations, the first thing I would suggest is to do your research. You know, take a look at the operating rule, take a look at what the plans are sending you, and compile the data to ensure that that is in fact the case. The second step I would say is to first reach out directly to the health plan. There's always potential for it to be a misunderstanding. The second step I would say then to take is to look to see if the health plan is Core Phase 3 certified. If the health plan is Core Phase 3 certified, they have you know, made a public commitment and tested that they are operating in compliance with the Phase 3 operating rules. If they are Phase 3 certified and you feel like they're not operating in compliance, you can submit a complaint to CAQH CORE. And finally, CMS does have a tool, it's called ASSET, A-S-E-T-T, where you can submit an anonymous complaint for HIPAA noncompliance with the administrative simplification provisions, including the operating rules. So it is on their website. It's fairly easy to get to. I would just Google CMS ASSET, and you can submit your complaint there. CMS has a process whereby they really try to work with the plan and the provider to reach compliance prior to inputting any penalties or fees or anything like that. So it's not a punitive process. They really work towards compliance and resolution.
Thank you, Erin. So we've gotten a couple of questions, asking about that health index webinar. What can we say to folks who want to register?
Oh yeah, so registration for the webinar will open in the early December, so it's not open yet, and I apologize for if that did not come across clearly. So if you're looking to register, like I said, it's going to be held on January the 12th, but everyone on this webinar will definitely get an invitation to it, so just stand by a little bit longer, we'll have it open for registration. Thanks.
That's great. So my next question, I think it's directed to Priscilla. So, but there might be other speakers who have this information as well. What are the average per item cost savings moving to ACH for healthcare payments? So is there some ROI information out there?
There is some ROI information out there. The CAQH index report has some of that information regarding what the providers save and what the health plan saves. We have again, NACHA has a case study that is showing that a hospital moving to EFT and ERA was able to reduce their receivables cost by 70%. As I indicated earlier, the other case study that we had showed a significant savings and the improvement in the days in accounts receivable in moving to electronics. But the best place I would suggest is going to the CAQH index, and we'll be interested in seeing the new report that's coming out in January to see what the new numbers are.
Thank you so much, Priscilla. We've got some questions coming in, about the reason, the barriers to doing this is delay with their clearinghouses and vendors. So providers are interested in this, but are having issues with their providers and vendors. Is there something that we can say to them that would be helpful, some information we can provide?
Maybe I'll start. It's Rob here. And one of the challenges is that a lot of practices don't have the software in place in order to take advantage of the EFT and other transactions. So for those practices that are looking at the new MACRA regulation and trying to decide how best to participate in that program, if you're looking at upgrading your technology, look to upgrade your practice management system software and have a list of questions for your vendor that include, can I take advantage of EFT and ERA standards and the other HIPAA mandated transactions? And maybe one quick pitch as well, the CAQH index is critical for us in the industry to understand what the real costs are to conduct the transactions and what the potential savings are. And Raynard, is there a way for our audience members to get involved directly with the index? Can they share their information with the index?
Yeah, I was going to say, it's also, if you go to caqhindex.org, it's also a way that you can get information about participating. And you can always just send us a note. There's a way on the webpage very easily just to say, get more information, and we're happy to share. We do open up participation to all provider organizations as well as all health plan organizations. And we do provide, as I mentioned earlier, benchmarks for any company that's interested in participating. You get a benchmark that compares your cost and your adoption to the industry and other types of entities similar to you. So if you're interested in participating, you can, one, just say I'm interested in the question box here, and I can always follow up with you, or feel free to visit us at caqhindex.org and we can chat further.
That's great.
This is Priscilla. I want to add one thing on to Rob's statement. I know we're almost done, but when you're asking your questions of the software vendors, and when you're talking to them about the being able to accept the HIPAA transactions, also ask if they can do auto reconciliation of the EFT and ERA, because that's when where you're going to get your most value for taking those transactions. If you can auto reconcile and then auto post to your patient payments. So add those 2 questions to your list. Thank you.
That's very helpful. Thank you, Priscilla. And it looks like we're out of time today. I'd like to thank our speakers and also thank audience members for taking time out of their busy schedules to join us. Here's information about our next core webinar. In the next slide, you'll see if you have questions or if you want to learn more, here's some links and ways to reach us. And finally, please take a moment after the session to fill out a short evaluation survey. We welcome your feedback. We'll be sending you these slides and a copy of the recording in the next 24 hours or so if you want to keep this deck as a resource. And besides that, have a great afternoon. Bye-bye.